Can we have Dr. NAREN Shetty also presenting his when he would not advise a phakic IOL before we go on to a brief set of questions? Dr. NAREN?
Yeah, thank you so much, ma'am. Let me just share my screen, ma'am. One sec.
Good evening, everyone. On this onset, I would like to thank AIOS for giving me this opportunity. Today, I'm going to talk about when not to do.
We can't hear you now.
Refractive surgery, phakic IOL implants has really gained popularity. Now, there are many indications to implant a phakic IOL. Other than just a virgin eye, you can also use it in post-refractive, post-cross-linking, even stable keratoconus, post-keratoplasty, and in piggyback IOLs in post-cataract surgery. But let's talk about what's a good surgeon. A good surgeon knows how to operate. A better surgeon knows when to operate. And the best surgeon knows when not to operate. So let's look at when not to do a phakic IOL implant. There are many contraindications in implanting a phakic IOL. So let's go one by one. Now, one of the things are age. When the age is less than 21, better to avoid because usually the power is not stable. And if you go and try to avoid implanting these lenses beyond 50 years, because usually some amount of cataract changes are there, also determining endothelial cell count and lens thickness and so on and so forth. Now, the other thing we really need to look at is the endothelium. When we have corneal endothelial count less than 2,500 at 20 years, it's better to avoid. And also if the count is less than 2,000 at 40 years, again, it's better to avoid implanting these lenses. Now, anterior chamber depth is one of the most talked about factor when you're implanting a phakic IOL. And usually it's better to keep a cutoff of less than 2.8 millimeters of anterior chamber depth. That is if you're calculating from the endothelium to the anterior surface of the lens. But if you're planning to start your phakic IOL implant practice now, it's better to keep a cutoff of 3 millimeters. But I personally use less than 2.75 millimeters as my cutoff. But we shouldn't only look at the central ACD. We should not forget the periphery also. This is one of the things which normally all of us keep forgetting is to do gonio. So if the angle is less than 30 degrees, better to avoid because there's a higher risk of angle closure, glaucoma post surgery. Also look for signs of any kind of inflammation in the eye, be it telltale signs or even active signs. If you see any of these traces, better to avoid implanting these lenses. Now, the next thing is you have to look at the iris structure. If you see any ciliary body, ciliary iris cyst, it is not a contraindication, but when you see multiple cysts in multiple quadrants, you need to be very, very cautious. Also look at the iris configuration. If there's any abnormality in the iris configuration, it can lead to, again, angle closure glaucoma because of abnormal positioning of the lens and further closure of the angles, and you can end up with a lot of issues post-surgery. Pupil size is something that normally all of us don't look at. Always look for pupil size, and if you have a mesotic pupil size more than 6 millimeters, better to avoid phakic IOLs. There are different companies which give you a larger optical size. They really customize to your needs, but generally, I think it's better to have a good cutoff of mesotic pupil of more than 6 millimeters, because this can lead to a lot of hairs and bladders. Now, you have to keep in mind also, depending on the power that is power of the IOL which is being implanted, the size of the lens and the size of the optic can change. So keep that in mind and then plan for the surgery. Now, cataract is one of a major factor which you shouldn't implant. But if it is a developmental cataract or a non-progressive one, you can still implant phakic IOL. But if it is a clinically significant cataract in the visual axis, and also if it is present in the presbyopic age, better to avoid phakic IOLs. The next is the retina. If you see cases where we have myopic CNVM or stage 2 or above macular holes, better to avoid implanting these lenses. But if you see in the periphery a few lattice and degeneration or holes or breaks, you can always do barrage lasers, and after 2 weeks you can take up for the surgery. One of the things also we need to keep in mind is if the patient is has a lot of liking for laser surgeries and not very keen, please do not push the patient towards phakic IOLs. Or if they're not at all interested with phakic IOLs, please don't do it at all. That is one of the contraindications also that we need to put in our list. So what we need to do at the end of this full discussion, we really need to sit with the patient, explain to the patient all the pros and cons, and make sure the patient has more realistic expectations. So let's look at a few cases. Here's the first case where we have a 30-year-old old lady coming for refractive surgery who has -10 and -2 cylinder in the right eye and -9 and -1.5 cylinder in the left eye. With the 6/6 parts best corrected vision, patient has clear lens and the fundus is all within the normal limits. This is how the topo looked at. But when we look closer at the scans, we realize the pentacam picked up the PNS of 1. So that means in our busy OPD, there's a very high chance that you can miss out these subtle changes of cataract in the lens. So please take your time when you see the slit lamp. Make sure you don't miss out these small things, because once you're done with the surgery, then you explain to the patient that you already had preoperative cataract. Patient will not be convinced at all. So the next thing is, this is case 2. Here's a 28-year-old gentleman who came for refractive surgery, who right eye had 0.5 with 6/6 vision, and the left eye was -2 cylinder with 6/6 vision. So the patient had the clear lens and myopia, the fundus was perfectly normal. Now this is the topography, and the patient wasn't suitable for any of the laser procedures. So what do? Do we implant a phakic IOL? No. We need to monitor these kind of patients, and we need to make sure that the KC is stable. So when the KC is unstable, then you do a phakic lens, then you will end up with trouble, because there's a lot more treatment required to stabilize the cornea when you have a KC. Thank you for your time.
Thank you, Dr. Naren. So let's start off with a great talk. Let's start off with just a few questions. I think I'll take the first question with Dr. Kamal. Are you there, Dr. Kamal?
Yes, I'm there, very much there.
Now, this is something we might transgress if at all, but I don't think we should. AC depth of 2.7 millimeters. Would you suggest a phakic IOL? Does
okay, now I think at 2.8 also is not the actual cutoff. I think what matters is the lens rise that I have, the angles that I have, and if I'm operating a hypermetrope, then even 2.8 is not my cutoff. I would rather have a cutoff of 3 millimeters, because a hyperopic lens is shaped and designed far more differently than a myopic concave back lens. So the golden rule of 2.8 probably doesn't hold true. Yes, but I think when we are talking on these forums, we are responsible for a lot of audience who are listening to us. So having a 2.8 cutoff is a safe cutoff. But one word of caution for beginner is, if you're going to treat a hyperope, do not think below 3 millimeters. Look for lens rise and look for angles. That's one. Number 2, if you're looking at a keratoconus patient, 2.8 is again not your bandwidth, because in keratoconus patients, a lot of times, if it is a central steepening of the cornea with the frustae or a central steepening, you may get a false anterior chamber depth, whereas suddenly it has a Stalling effect. So I remember, you must remember in last session we had on this, where I did present 2 cases like that. Anterior chamber depth was 2.8 and everything looked normal, but the patient totally, behaved contrary to what we were expecting. So 2.8 is a good mark for normal standard cases. Very flat corneas, 2.8, not good idea. Keratoconus patients, 2.8, not a good idea. Hyperopic patients, 2.8, not a good idea. But yes, I have operated at 2.65 also in patients who've been kindly observed. I've counseled them that, okay, we are trying this. If it works out, great. If it doesn't, you will be ready. We might have a cataract, and I've got away with it. But you cannot do that every time. So I think 2.8 for a normal standard case with your standard keratometries, good angles, good lens rise, not high lens rise, more than 600 microns. These would be few borderline cases where I would stick to the dictum of 2.8. Otherwise, I would like to use more levers to find where I stand properly.
Okay. Dr. Ramurthy, I would want to ask you, continuing on this, would you think a 2.8, 2.7, and you think you can get away by doing a YAG PI? Does it make any sense at all? Dr. Ramurthy, are you there?
Yeah, I'm there. No, 2.8 is what I go by, even for hyperopic eyes. If it's 2.8 millimeters or more, we go with that. We don't go less than that. And most of these lenses, whether it's Indian or imported, comes with a central flow now, with a central opening. In these cases, I think doing a PI doesn't really add much value. So if that's not going to work, so I stick strictly by 2.8, and also give some credence to the angle. If it is less than 30 degrees, then that's again a relative contraindication. But unlike, I would agree with most of what Kamal said. Only thing is, even in hyperopic eyes, I am aware of the difference in the profile of the lenses. In myopic eyes, it's basically plano-concave, while this is plano-convex in hyperopic eyes. But and it's slightly thicker in the periphery. But still, we stick to 2.8 millimeters. I have not come to grief. But I don't think there's any point in making a PI and saying that I compromise on the thickness and the AC depth.
And I think it is most important that we do look at the angle, and an angle maybe not necessarily 30, even up to 25. You could allow an open angle, and you could go ahead. And a YAG PI is after all done for a pupillary block. It is not that allows you to justify stepping down on your AC depths at all. And with a center of flow, where is the question of a pupillary block occurring? Taking you to a different setting, a 35-year-old pre-presbyopic with a 3 diopter power with good AC depth. I would want Dr. Purendra Bhasin and Partha to comment on this. A 35-year-old with a +3 diopter power with a good AC depth. Would you talk of a phakic IOL, or would you consider a clear lens extraction +3 diopters?
+3 diopters, 35 years old. I will prefer, if the anterior chamber depth is adequate, then I will prefer doing phakic IOL. In such cases, because she still have 5 years in hand where she can be spectacle free, she will not require presbyopic lenses. And had the refractive error very high, like 7 diopters, 8 diopters, or like that, then I would have gone for thought for a refractive lens exchange and with multifocal or trifocal lens. But in this case, I will prefer going for the phakic lens if the anterior chamber depth is adequate.
Why would you? You are not anyway looking at a presbyopic IOL. So how does it matter if it's LASIK or a phakic IOL? Why would you not prefer a LASIK for a +3 diopter?
LASIK, if it is corneal thickness is adequate, then definitely. Because the question was hyperopic, if it is, then we can go for LASIK. Definitely. LASIK is a good option. Second option will be phakic lens. That is one. First option is LASIK.
Partha, your thought on it. Let's ensure that a hyperopic phakic IOL doesn't have the center of flow. So would that sort of deter you to consider a phakic IOL, or would you still do LASIK, or you would still do phakic IOL? Your thoughts?
+3, I would definitely, my first choice would be LASIK. If LASIK is not possible, then only it would be phakic IOL. I would not like to do a clear lens extraction for a 35-year-old with a +3.
Okay. But then if the third kind of scenario comes in, wherein it's an 18-year-old here with a +4 diopters. So would you wait, or what would be your approach? Otherwise, any of you expert panel could take that.
Definitely with an 18-year-old with the hyperopia, it's very judicious to wait at least 1 or 2 more years with proper cycloplegic refraction every 6 months. And when one is absolutely sure that the hyperopia is stable, then go in for the laser vision correction.
Ramurthy, you want to add anything?
Yeah, just a comment here. Hyperopia doesn't progress in the sense that myopic eyes become larger. So you want to wait till 21. In hyperopia, it's a smaller eye. It's not going to become any smaller further. The only challenge here is the difference between what is manifest hyperopia, what the patient accepts, and what is the actual hyperopia. So doing a good cycloplegic refraction with hometropine is extremely important. And also pushing the patient to accept as much plus power as possible is important. In case under cycloplegic refraction, what you find is there is +6 diopters, and the patient is not, even after fogging, is not able to accept beyond 3.5 diopters, I'd hold my hands. It's not because the hyperopia is not going to be progressive, but because the patient is at this point of time is not going to be comfortable with a full correction. So I would go as much as putting about 4.5 or so, even though the patient might have a certain, initially a certain problem. As accommodation relaxes over time, you would find that the patients are accepting quite well. So if there is more than a diopter and a half of difference between the patient's acceptance and what is measured by a objective cycloplegic refraction, I'd hold my hands as far as putting in phakic intraocular lenses in hyperopia is concerned.
Dr. Sri Ganesh, are you there? Dr. Sri Ganesh? Not there. Dr. Titya, would you want to add something at this point?
I think the point is well, discussed. Nothing much to add. We all understand, refractive procedure needs to be assessed as per the requirement of patient. There are people, hyperopes will always demand a removal of glasses, and given an option, I think LASIK or laser vision correction will be the first choice in these cases, unless as Purin rightly told, if the refractive is very high, then you can go for clear lens extension, and hyperopes do accept these options very, very nicely as compared to myopic patients.
Anaga, would you want to add anything to it at this point?
I wanted to ask the panel regarding their choice, whether is it 18 years complete or 21 years complete for a phakic IOL even in a myopic patient? With
Yes,
stable refraction.
Stable refraction for 1 year.
Refraction, assuming stable refraction, would you consider
That is the first criteria.
-20? No, sir, that's what. If assuming that it is a stable refraction, say -20 diopters, would you consider at 18 complete or 21 complete?
I think it depends, if it is a male counterpart, then 21 is a cutoff. If it's a female, you can go for 18 years.
How is that?
So, but why?
I think it's true.
Assuming that she's not going to get married.
No. I think the refractive stabilization is
not like that.
Yeah. It depends on a totally refractive stabilization. Yeah.
One other factor I would just like to mention is, nowadays we are more concerned about the regression after laser vision correction also. Even in a 24-year-old, maybe the patient comes with a -8 diopters, cornea is very thick, everything is quite normal. What I have found over the years is that whether you do SMILE or whether you do femtolasic, after 4, 5, 6 years, many of these patients start developing a small amount of residual error, small regression that comes up. So some patient who repeatedly keeps asking whether the correction that you are going to do is going to be absolutely fine, I tend to shift more towards phakic intraocular lenses, because it's like putting a perfect glasses inside and it serves the patient very well till they become presbyopic. Second thing is about the quality of vision. Even though we have so many different nomograms and then laser vision correction, there's always a certain drop in the quality of vision when we go on to higher amounts of refractive error, both hyperopia and myopia. So if that matters a lot to the patient, again, I tend to go for phakic intraocular lenses because there's no distortion of the cornea that you do with the by a phakic intraocular.